Now, this is a rather maybe strange combination of terms. And so we'll describe this a little bit. Why epidemiology and compassion and love? Say we had 70 people participating, a variety of perspectives, and a real rich conversation. The two key questions that we were focused on were the extent to which epidemiology, the science which undergirds global health, can further or advance our understanding of compassion and love, their dynamics, their transmission, as well as can epidemiology promote, guide, and help us realize a compassionate or loving world where compassion is a key driver for quality health services. There are several uses of epidemiology, and we considered some of these. One of the primary uses of descriptive epidemiology is to describe our experience in the world. How and why do things cluster according to time, place, and person? Why is it that the world is not just homogeneous in our experience? It occurred to us as we began thinking of this meeting that our experience of compassion, our experience of love, are clustered. They occur sometimes in more intensity and maybe different qualities at certain times, maybe in certain places. And certainly we experience this differentially from certain people or towards certain people. So could epidemiologists help us understand the nature of compassion and love? Epidemiology also is useful in identifying causes of phenomenon of interest, risk factors, and of course we use these for understanding risk factors for disease. In the COVID pandemic now, we see age and underlying illness as risk factors for severe disease. Epidemiology also allows us to develop and test interventions, measure the effectiveness of these interventions, and then help us use our resources widely in promoting and expanding the most promising and cost-effective interventions. But for us, in considering the epidemiology of compassion and love, this last use of epidemiology may have been the most important reason for us convening this meeting, and that's to monitor progress toward goals. The epidemiology of compassion and love are not just academic questions right now. We have the Fetzer Institute doing its best to support programs to create a more loving world. We have cities and communities that have identified themselves as wanting to be compassionate. They've signed this charter for compassion, and they're trying to measure how well they're doing to achieve the goal of becoming a compassionate city. We have countries, ministries of health doing pioneering work, such as that in Ethiopia, where the health sector transformation plan includes compassion as one of the fundamental features of its transformation plan. How will the Ministry of Health in Ethiopia monitor and measure progress? What interventions will they use to create a compassionate healthcare system? The WHO Global Learning Laboratory for Quality Universal Health Coverage is really leading this effort to identify and conceptualize compassion as essential for quality universal health coverage. We know this intuitively, but WHO has made this explicit, and they're focusing, as we may hear more from Shams, on compassion at these 4 levels of the patient, the healthcare facility, the organization, and the national level. WHO has boldly claimed that compassion is the heart of quality, people-centered health coverage. I'd like now to review a little bit of the meeting, walk you through the agenda for that meeting, and share some insights. We initially started out with some epidemiologic principles to get everyone on the same page. We had a variety of disciplines represented in the room. Many of them were not epidemiologists. Then we focused on the conceptual foundations of compassion and love. And I think all of us listening today probably have a slightly different definition or maybe experience of compassion and love. But we heard from the conceptual foundations and the reflections from a variety of disciplines: psychology, neuroscience, religion, and philosophy. And as you might expect, the issue of definitions and coming up with a conceptual foundation that we can all agree on is one of the big challenges. We then heard multidisciplinary perspectives, people who are really working at the individual level, cultivating compassion. Organizational compassion. What are the mechanisms and processes that make an organization compassionate? And then also compassionate communities. What makes a community compassionate, and how might we measure that? We then considered the existing evidence, which is fairly robust, that compassion actually can be cultivated if we desire and we allow ourselves to be open to training and to reflecting and becoming more compassionate. The evidence suggests that that is possible. We reviewed the evidence from several programs focusing on compassion training, both in healthcare systems, education, leadership. And we also heard about compassionate organizations, organizations that cultivate flourishing, and looked at some of the scientific evidence, which was quite encouraging. We then tried really hard to grapple with this issue of measures and metrics. How do we measure compassion? The absurd question arises, what is one unit of compassion or one unit of love that an epidemiologist might count? Well, there are measures to assess compassion at the individual level. These are largely self-report measures. Are you compassionate? Did you experience love in a certain way? As you can imagine, self-report may not be the most reliable measure. So there are also recipient perspectives. That is, patients, for example, can be asked, did you receive compassionate care from your healthcare provider? There are also a range of objective measures. Was the behavior actually compassionate? That can be observed. There are brain imaging techniques that allow us to look at the neural pathways for compassion. And there are physiologic measures that correlate with compassion. Now, do these line up exactly with our internal experience of compassion? Are they transferable from one setting to another? These are some of the questions that we wrestled with. We then heard from 3 donors who also participated in the meeting, foundations, the Fetzer Institute, the Templeton World Charity Foundation, and the Izumi Foundation. These are all foundations that have compassion as part of their mission or that embody compassion in the grant making that they do. We then considered spatial epidemiology. How is compassion and love, how are they distributed in space? There's a lot of work that's been done on spatial epidemiology, and we had Lance Waller, who's one of the experts in this global positioning systems and geographic information systems, share his perspectives with us. On the right bottom of the screen, you can see the cities in the United States that have identified themselves as compassionate and have signed the Charter for Compassion and are working towards becoming more compassionate. We can map proxies for compassion in a range of ways, and we explored these. And then finally, we investigated epidemiologic methods. Some of the interventions that I mentioned, compassion training, have been subjected to very rigorous randomized controlled trials, and others have not yet been. And so what are the methods that we need to use to really identify the most productive and promising interventions or programs to increase compassion in different settings. There was also a concern that compassion and love are so precious, they're so personal to us, that we don't want to have a reductionistic perspective on this as we try to use metrics to advance our goals. There were three main outcomes of the meeting. There were a number of products that were envisioned and we're starting to work on these. One will be a report of the meeting, which actually has a draft of which has been sent out to the participants. We anticipate getting responses from them by May 10th, and by the end of this month, by the end of May, we'll be sending that to all of you as well. We want to develop a compendium of measures and metrics. We want to develop an advocacy paper that links the Sustainable Development Goals with compassion. And Liz Grant, one of our reflectors today, will be leading this effort. There's probably a huge public health burden related to the absence or lack of love and compassion, and that needs to be fleshed out and described. And then a series of briefing documents linking compassion and quality health services is envisioned. Research is really needed to advance this field. As I mentioned, we need to do more work on the conceptual foundations of compassion and love. We want to understand, how are these things transmitted? What's the nature of this transmission? We can also start using the existing measures, say, for compassion, particularly at the population level, to learn, are they translatable across cultures and different settings? We need new measures, and some of these are coming on board now and can be tested. We need to learn more about compassion interventions in organizations and communities. We have a fair bit of information on individual level, cultivating compassion, but not at these larger levels. And we may need some innovative epidemiologic methods. And then finally, the group was very dynamic. It was so refreshing to be in the room with people from different perspectives, but really committed to creating a compassionate and loving world. And so we want to convene working groups to focus on some of these products. We want to continue with the global health compassion rounds, which we're having today. And we want to extend and collaborate the partnerships to really build this new field. So with that, I'll close. There may be some time for questions during the question period, but I really wanted to share with you some of the essence of this meeting. Again, our report will be out to all of you in May. And I also invite any of the participants, the reflectors, you too, Shams, who participated in the meeting that want to add any comments, please feel free to do so. Thank you. With that, I will turn it over to you, Shams. Thank you.
Thanks very much, David, and greetings to you all. My name is Shams Saeed. I'm currently the lead for quality of care here at WHO. It was wonderful to hear that walkthrough from David on the technical meeting that he convened in Atlanta. And there really is a depth of content that we will need to examine carefully from the proceedings of that meeting. Today, of course, is a very different world, and latest figures from this morning, and I think all of us will be reasonably familiar with these data, but just to emphasize, nearly 3 million confirmed cases now, 204,987 confirmed deaths, and 213 countries, areas, or territories with cases of COVID-19. So all of these numbers are, of course, people, and all of that exploration that David was going through, and the depth of that exploration needs, of course, to be applied to the world that we are living in today. And what does that mean for us? And that's the task that David has given me for the next 5 minutes, just to have some reflections on what that means. It of course means many things to many people on multiple fronts. And each of us will of course bring a certain lens to that discussion. What is the role of compassion in the world of COVID-19? I bring a specific lens to that, and the lens that I'd like to share with you is related to health services and the quality of health services, and how compassion is intimately linked to that. Before even making any reflections, of course, just to emphasize that, of course, it's much more than health services, and we've always emphasized that the whole of government and whole of society approach to all matters, but particularly COVID-19. If we look at health services and the quality of health services, perhaps we could think about it in two tracks. One is the role of compassion in the care of patients with COVID-19. And secondly, the role of compassion in maintaining quality essential health services. And this is, of course, increasingly being highlighted, whether that be for care for mothers, newborns, and children, whether that be for communicable diseases, whether that be for non-communicable diseases, or a host of acute emergencies that are non-COVID. So those two tracks may give us some anchor to think through in relationship to compassion. And this is, of course, a delicate balance requiring some difficult choices in some of the more difficult places on the planet, but also, of course, the adversity associated with COVID-19 brings something to that equation anywhere on the planet. And compassion plays a critical role in that delicate balance. Looking further, and David has already alluded to this, we can think this through in terms of 4 entry points. One, the point of care. So all of us have heard so many wonderful and heartwarming experiences related to the point of care and how compassion makes a difference. We've also heard the second piece is the interaction between health workers within a health facility and the role of compassion in bringing that glue to health workers who are working together in health facilities. The third area, health organizations and the function of health organization. Compassion has a role in that, and we're hearing more and more about that throughout the world. And importantly, the fourth level, the national direction setting and action. And of course, compassion has been a core part of that discussion in many parts of the world. So examples of that abound, and I'm really looking forward to the discussion today because we've got a range of reflectors that will bring different perspectives to that discussion. We recognize that this is an area that we continuously will need to learn. As David has highlighted, it's an area that has required in-depth exploration, but at this time, it requires in-depth exploration in real time associated with the action that's required, and action in some of the most difficult situations on the planet. My Director General, Dr. Tedros, has emphasized on a number of occasions the critical importance of compassion and in the current COVID-19 situation. And in fact, he's highlighted that compassion is a medicine. And it's something that we shouldn't take lightly. And those of us who are involved in thinking through the work on compassion, I believe has a duty to bring the thinking to the field and the field back to the thinking. So with that, I'd like to hand back to David, and I'm really looking forward to the reflectors and the discussion in these rounds today. Thank you, David.
Thank you very much, Shams, for those reflections. We'd like to move now to our respondents, or reflectors, calling them. The first will be Maria Rebollo, who's the team leader of the expanded special project for elimination of neglected tropical diseases, ESPN, which is part of the Afro WHO regional office in Brazzaville. Maria?
Thank you so much, David. As David was saying, I work on neglected tropical diseases, and as we all know, the NTDs are diseases related with poverty. And of course, when you live in poverty, you are deprived of your most basic needs, and somehow your life is a constant effort to try to meet those needs. And in that sense, we could say that people that live in extreme poverty are already in the fight for survival, even in the absence of any pandemic. And I was listening very carefully when David was saying how difficult it is to define compassion, and I look forward to learn more about how we define it properly. But somehow, intuitively, we think that compassion is related with understanding the suffering and the pain of others and being able to understand their needs. And in that sense, I just wanted to share with you humbly some reflections on how much we think the special needs of the people that live in extreme poverty have been taken into consideration when putting in place some public health measures, and how much they have been actually consulted on this decision making. I live in Brazzaville, in Congo, where, if I am not mistaken, there is around 200 cases of COVID-19 being declared so far, and around 8 people declared to be dead by coronavirus. And we have been now in 1 month of lockdown already, which means that all economic activities are forbidden, with the exception of selling food 3 days a week. But all the rest of the days, everything is closed. And that means that the carpenter that used to work in the corner trying to do beds cannot work, or the Ministry of Social Affairs is closed, or everything is locked down, with the exception, as I said, of selling food 3 days a week. And also, there is no transportation, there is no taxis, no buses, in a country where there is very few people that have a private car, so it means that nobody can go anywhere except walking. And in that context, when you go to the streets in the 3 days a week that is allowed to buy food, you see a situation that the streets are full of people, so it looks something between an exodus and a festival. And you see people transporting something somewhere. You see old ladies carrying like a massive package of food in the head and walking miles and miles. You see young guys pushing a cart with massive big sacks of food. You see other young guys carrying all women in the cart, or pregnant women, trying to transport them. And when I talk about this type of transportation, I'm talking a super hot weather, like under the sun, people having to walk miles and miles or kilometers and kilometers to try to go places. And at the same time, you see that the city of Brazzaville has become a massive market. So the social distancing is really not being maintained, because people, for this survival need, they need to try to sell something. And because the only thing that is allowed is to sell food, one person tried to sell bananas, other person tried to sell oranges, other tried to sell peanuts. So everybody's trying to sell something. And it has become a massive market. And in that sense, despite the fact that you have the army and the police in the streets, you can actually feel a sense of compassion from them, because they are letting people sell in every single corner. Things that were not allowed before, they are being very understanding and very compassionate and letting people be selling all over the place. And that is what you see on the 3 days a week that is allowed to sell something, that people are really trying to survive and sell something. And in that sense, of course, survival is one of our basic needs as humans, and that's the reason why these measures of lockdown for COVID-19 have been put in place, to try to prevent people to contract this disease. But in this type of poverty situation, survival may also mean that if you are a pregnant woman and you suddenly have an hemorrhage in the middle of the night and there is no transportation, that you cannot reach a hospital and that there is no way where you can be really receiving the care you need. Or that if you are a father of a family and live in poverty and you cannot do economic financial activity, you cannot bring food into the table of your children, and that may mean survival for you. Or also there are groups with special needs. For example, there are homeless children that typically maybe the people have compassion of them and they give them something, but in this type of situation where people are scared of their own life, they don't have that sense of compassion towards others that typically you would see. For example, I support some orphanages here, and just this week I went, even if I am not supposed to go because I am supposed to stay home, but I went to see how they were. One child was severely sick, and of course the person that is taking care of the orphanage, because he's worried that he can contract coronavirus, maybe he's not taking the child to the hospital. Or there were, for example, one of the little babies called Joshua, that he's 3 months old, he was being fed by corn instead of giving them the child milk formula, because it was finished and they were just trying to give him corn, and he was like really in a very, very bad status. So he didn't have diapers, they didn't have any of the basic needs, because these orphanages, they are in the edge. They live by the compassion of the people in the. They live from the compassion of people in the neighborhoods, and in these situations, is that sense of being able to help others is much reduced by the community. And for a little baby like Joshua, just 3 months old, the difference between eating corn or eating formula milk can mean life or death for him. And that is a situation that is a reality for many of the people that live in severe poverty. And maybe just to conclude, that other needs that we all have as humans is also the need to connect to one another. And in these types of situations where coronavirus has been so related with traveling, people have in mind like, oh, this is a disease of people that travel, and xenophobia has also increased. So you can see how people immediately are rejecting Chinese people or each of us, like any white person. The moment you go to the streets, people are, oh, you are bringing this disease into the country, because people don't have a full understanding and they are scared, and it's bringing all these sentiments of xenophobia. So in that sense, I just wanted to just share that reflection with all of you, that as we promote public health measures that are very important to protect people, we need to think on the needs of the special people that we are trying to serve, and that we need to involve them in the decision making and trying to understand their needs, so that we don't focus only on one of the diseases that we are trying to protect them for, but we also try to think on their overall needs and try to make sure that their overall needs are met and that they are engaged in the discussion. Thank you.
Thank you very much, Maria, for that report from Brazzaville. You raised several really key points for us that I think will be picked up on by some of the other reflectors. We have not apparently been able to connect with Dr. Teme from Liberia, so we will go now directly to a recorded presentation from Wilbert Pomeroy, who is with the Ministry of Health in Zimbabwe. He's recorded a presentation for us, which will be about 5 minutes, and then we will continue with Dr. Grant from Edinburgh. Thank you.
Thank you very much, Ashley. I'm Wilbert from Zimbabwe. Unfortunately, we experienced some technological challenges, so I cannot join the Zoom. But nonetheless, I'm so excited about the momentum that Compassion has taken and the deliberations that I've seen from the various reflectors. In Zimbabwe, what we have done in terms of Compassion is, during this COVID outbreak, is we have tried so hard to do customer care trainings for everybody in terms of how to counsel people, psychosocial support, because people will be afraid and they've seen videos of people dying alone in isolations. And we have a lot of quarantine centers where people who are coming from all over the country, the world, have to be quarantined for 21 days, and it's mandatory. So you can expect the pain, psychological pain that people go through. We have engaged the social welfare ministry to do much of this medical social welfare work and psychosocial support for these deportees. Some of them are deportees from neighboring South Africa and Botswana, who has never been home maybe for about 20 years, and they need to be reunited with their families, etc, etc. So as a quality department, we are taking a lead in terms of that to see that people are reunited and are given the transport to their homes of origin from the borders, as well as soliciting satisfaction, customer satisfaction, client satisfaction. We are doing a lot of surveys there to try and see our services, how they are being rated, and by the people in the quarantine and isolation centers. Then we go to compassionate leadership. I'm so excited to know about compassionate leadership, because mainly here we are driven from the heart, our compassion, and we have gone a step ahead to include compassionate followership, because it's a two-way thing. Because we find that when we have compassionate leadership and compassionate followership, you see more positive outcomes coming in terms of COVID. It's a disease that can even affect the health workers themselves. So managers and the followers need to really take that into consideration in terms of IPC, which is also under quality in this country. We have gone again to look at the palliative care that people are receiving, the psychological counseling as well, so that people are prepared, the relatives, to give care for those who are recovering at home, as well as the friends, the families. And in short, we have really made or created a health workforce which cares, which is so important. And compassion has become one of our elements or characteristics of quality in this country. We rate it very highly, together with safety, efficiency, effectiveness, timeliness, etc, those elements. So compassion has become icing on the cake, because we've seen that it will take us too far in terms of outbreaks and resource utilization, teamwork, and these other issues. So you find that we have engraved compassion in quality programming. We have managed to get to package it so well that it's palatable, it's so attractive to health workers, and they are enjoying. We have front runner sites like UBH in this country, which is running with this quality with compassion program, and it's bringing a lot of good and positive feedbacks from the clients. And I think for because of the time, I would like to thank you very much, and it's so unfortunate I cannot be in the Zoom. It would have been really nice, but I think Ashley will help me in trying to get some feedbacks from other people. So I think my 5 minutes is done. Thank you very much, people. Good work to David and Shams. It's fantastic, everybody. Ashley, thank you very much.
Thank you so much, Wilbert. That was really a wonderful presentation. Thanks for joining us, even though you couldn't in real time, and for your encouraging words. We do have Dr. Teme, who's available to speak with us now. I'm really pleased she was able to join us. Dr. Teme is the Clinical Coordinator for Patient Safety and Healthcare Quality at the Ministry of Health in Liberia. Lakile, can you join?
Yes, certainly, I'm here. I'm unable to put on my webcam because the video is disabled.
That's fine. Thank you very much. Yes, thank you very much. We can hear you loud and clear. Appreciate it.
Okay, so Okay, so just to jump quickly into my talk, I'd like to thank all the organizers for setting up this webinar, and I'm very grateful for the opportunity to speak on compassion, especially as it relates to all that is being done in Liberia. So looking at the guidance and the basic information we got to direct this talk, I think firstly it's very essential to ensure that compassion is considered at all levels of the care structure. Compassion has to be a responsibility of the community. It has to be responsibility of patients, of providers at the point of care. Compassion has to be a responsibility of the organizations that are involved with healthcare services, and in fact the entire health system. So one of the things we've been able to do is to ensure that we reach out to the community and set up these dialogues and focal group discussions where we're able to explain issues about COVID-19 during this outbreak. And we've been able to, at least to a certain extent, define the roles and our responsibilities at this level, because one of the things you see that is a continuous problem is the resentment of our patients or individuals who are identified as suspect cases or even confirmed cases, those who have gone to quarantine centers and returned back to the community. So we've involved psychosocial personnel to be able to reach out to the community and then prepare these communities to be able to receive these people. So one of the other things we think that we could beef up is the need to be more concerned with the vulnerable populations within the community, especially old people, the widows, pregnant women, and children, and those special needs that they have. So basically, we think that is a greater need for compassion at all these levels because, for example, we're seeking to eliminate the issue of resentment, stigmatization, and also issues with at the care centers where you have prolonged quarantine times and prolonged isolation as a result of the delay in test results and those kind of things that traumatize and put patients under stress. These things have also been worked on. Basically, issues with patient medical information being consistently confidential during this outbreak. So we have had instances where patients' medical information have been leaked to the public, even the press, without even they themselves knowing or their care providers. These are issues that we've been actively working with the system to settle. Basically, other issues we think that can help that have demonstrated the power of compassion is through volunteerism. So there are care providers are not compelled to treat COVID-19 patients because we have specialized centers where these providers are deployed at. So we have a lot of volunteers coming forward. I mean, people who experienced from the Ebola era, they have come up to help the system. And also local organizations have felt the need to intervene at the community level. So we also have an ability to cultivate compassion at all levels using a method to introduce this into medical training. This is something that is still on the surface, but we have to add a little more weight to it and make it a total part of clinical practice, and then encourage providers to pay more attention to making patients comfortable during the care process, helping family members and relatives at the community level to understand the medical conditions of their relatives, their family members, and how we contribute to ensuring that they play their part in providing the compassion this patient needs throughout the care process. So we also want to ensure that we continue to work with cultural and religious leaders to eliminate those barriers that you don't usually see in regular settings. So this helps us to also release and then improve compassion for the sick. So for organizations, we're trying to promote organizations, especially civil society organizations, patient organizations, to contribute more towards the advocacy process. We know what advocacy from patient groups does. It empowers, it strengthens the resolve the government to be able to act on these kind of issues. And also, we think that we need some level of redesigning of our system, especially low middle income countries where we have a lot of issues that impact compassion, like staff burnout, like staff satisfaction issues, and the overall issues that impact quality and safety at our healthcare facilities. We also need to strengthen compassion measures, especially identifying, introducing them, and making sure that people are complied by these measures to improve the overall compassion level for patients across the spectrum. Thank you very much.
Thank you very much, Lakile. That's really helpful to hear how systematically you're addressing compassion at these different levels, and really inspiring to us. I'd like to go now to Liz Grant, who is involved in a number of compassion initiatives. She's also professor of global health at the University of Edinburgh. Liz?
Thank you. Can you see me? Thanks. Can you hear me? Lovely. Thank you. So it's tremendous just to be part of this conversation today. And what I'm going to speak about is how our understanding of compassion within a very particular area, that of palliative care, and especially also how not just the COVID disease has impacted on palliative care, but how the impact measures, how the mitigation strategies that public health are using are also affecting our palliative care situation and context. Because pandemics and these public health measures are actually posing enormous existential threats, as Shams and David has said. And our challenge is to balance the messages and balance what's happening in the world today, where physical and psychological and social and spiritual suffering caused by the disease and caused by the fear of the disease. And as the various reflectors have mentioned, the fear of the symbolism of what the disease stands for, the fear of the messaging, the fear of resentment, of stigmatization that's happening. And the mitigation strategies, the lockdown, the quarantine strategies, which have been so essential in trying to flatten the curve or crush the curve, as the New Zealand is talking about, have had very positive intended consequences. The disease has, in many cases, this is the only way we can move forward. But they've also had unintended consequences, and other intended consequences that we never envisaged. And those are around how nature is flourishing and how planetary health is actually beginning to see what can be done when carbon emissions are reduced. But I want to talk about these unintended negative consequences of our public health measures, because they have come at a huge price. Maria and Wilbur and Dr. Tequila all talked about the people who were being left behind, the vulnerable, those who were excluded, the homeless, refugees, those at the outsides of society. And we know this disease is really impacting also those who are elderly, those who are have underlying conditions, those who have many comorbidities. This disease is influencing and shaping the way that we understand palliative care, because palliative care is about caring for those living with life-limiting illnesses for the last years and the last months and the last days of their life. Palliative care is about alleviating suffering. Suffering is how we experience pain. And the term itself originates from the word pallium, the word to cloak, to cover, by extension, to give comfort. And at its heart, palliative care is grounded in compassion. Compassion that values life, but compassion that also values death and dying as part of the normal process of life. And how compassion is embodied in the acts of caring for people at this stage has been, a light has been shone on it through COVID. Now there's two as we talk about balancing, there are two things that are happening. COVID-19 is demanding palliative care because, as Shams mentioned at the very start, the numbers of people who are dying are escalating every day. We need more palliative care, and many countries don't have sufficient palliative care services anywhere. But those with palliative care needs who are there, were there already in our societies, those people are not receiving the palliative care that they need, many of them in the face of the new pressures that COVID is putting on our health systems. So we're in this balancing act. And we're in this balancing act for for some reasons that I want to flag up. As priorities have been reset and life-saving measures are obviously fundamental, our systems are being judged on reducing the numbers of who are dying, which is absolutely right. Death is being treated and seen as a failure. But palliative care is about managing death. So what we need to do is look at how do we accept the inevitability of death without disregarding the care of the dying? How do we prevent preventable deaths, but ensure those who are moving towards death are cared for properly? How do we make the ethical decisions around resourcing effectively? Especially in these moments when every country, every society is challenged by not having the right resources to offer care. Some of the lockdown issues I just want to frame today and show how they are impacting those who have palliative care needs. Unfortunately, we know that many people with palliative care needs are actually being prevented to get to health services. They're prevented to get for access, and some of that access is about transport not being available, understandable curfews being placed, but as Maria described at the very start, those who are trying to get outside during curfew hours are not able to travel. Those who have no longer any money to pay for the transport. Routine services have been closed. People are fearful to go to clinics in case they get COVID. People who are ill are obviously more at risk already of COVID. So there's a fear, families are fearful to go. There's myths around what COVID will do. And that has stopped the access to health services. As Shams mentioned at the start, we need compassion needs to encourage the whole of the health system to work together. COVID, the lockdown and the mitigation strategies have prevented treatment options being available. There's many resources and medication that's just not there any longer. There's a lack of access to PPE for those with COVID, who are treating those with COVID, but there's also a lack of access of resources and equipment and certainly a lack of access in the homes. It's reducing the care options. It's exacerbating and creating additional problems around mental health. Those who are on their own are suffering. Those who are on their own with palliative needs are suffering greatly. They need to talk. At the time of death and dying. People need to talk, need to be with each other. It's part of our culture, tradition, religion to be together. But unfortunately, lockdown mitigation strategies are preventing people from being together. It's exacerbated the risks within intergenerational households for those who have palliative care needs. How do we keep children who are least vulnerable but potentially carrying? How do we ensure that separation when there's not opportunity to split and divide households? And in care homes, we're seeing situations where clusters of people are dying in nursing homes. And families are really struggling because they're no longer able to access the nursing home to see their loved one, to say goodbye properly, though this is changing, but it's an area. Palliative care really encourages us to spend time and to look at helping people to come to terms with death and dying. And COVID is a rapid death. COVID-19 is a rapid death. We need to think about how do we ensure that that families can be given that opportunity to be together compassionately in the midst of ways of separation. Funerals and religious rites and rituals have been prevented from happening, understandably. But again, this is in the process of grieving, being able to be together is something that we have in palliative care really worked towards, and now we're having to re-articulate what that might mean to be together spiritually, but to be physically distant. In the last moment, I just want to ask a couple of questions, because the mitigation strategies that we have in public health that are so essential are strategies about separation, and separation of necessity involves spaces, creating division. But how we fill those spaces is where compassion will come in. What's in the space at the minute is fear and anxiety, sometimes magical thinking, people being rushed out of the villages, there's anger, shame. How do we frame the spaces? How do we frame those spaces of isolation? And how do we fill the spaces with compassion? How do we fill the spaces where there is you and I together, where there's empathy, where we can move beyond the anxiety and come together? Palliative care is about giving people the space to become what they need to be in those last moments and days and months. I'm going to finish with a quotation from an Irish poet and an Irish monk, John O'Donoghue, in his book To Bless the Space Between Us. It's a book of invocations and blessings. And it's about, he says, there's something really important in coming together, even if it's coming together through words without physical contact. May all that is unforgiven in you be released. May your fears yield their deepest tranquillities. May all that is unlived in you blossom into a future graced with love. And in those words, that sense of coming together that palliative care offers, I think compassion sits at the very heart of that. It begins to extend how we care for others. Thank you.
Thank you, Liz. Those were really wonderful words and of wisdom and also inspiration and challenge for us. So thank you very much. These first four presentations have been so rich and wonderful, and we would like to actually continue now with the other presentations so that we have some time at the end for questions for all of the presenters and discussion. We've received several excellent questions, and we hope to get to at least some of those at the end of our time today. And if not, we will record these. We will try to parse them out to the different presenters so that some of you who are asking these questions have a way to begin the conversation or continue your own conversation with us. I'd like now to turn to Jane Chun, who's the Program Director for the Compassion Institute. Jane, it's wonderful to have you here. Please go ahead.
Thank you, David. I'm really humbled and honored to be here with all of you. And thank you to the task force and David and Ashley and everyone on the team for making it possible. So I'm calling in from New York City, and I'm a program director at the Compassion Institute, managing our work in healthcare. At the Compassion Institute, our mission is twofold: compassion advocacy and compassion education and training. I'm also joined by our founder and president, Thupten Jinpa, and I'll be presenting on behalf of us, speaking specifically to our work in healthcare in response to the pandemic. Just before I get into what we're doing, I just wanted to take a step back and share with you a framework that's been helpful for me in thinking about how to make decisions and respond in this complex environment. And that's called the Cunefin framework. I won't go into it just out of respect for time, but it's a framework that helps decision makers to think about how we perceive a situation and make decisions and how we respond in different types of situations. So the world 6 months ago was very different from the world we're in now. And this framework describes different types of environments and situations. And I think right now we're in what the framework describes as a complex environment. And in complex environments, the cause and effect relationship is not so obvious when we're in the situation. It's only obvious in hindsight. And there are a lot of unpredictable emergent qualities happening. And so the decision model and how we make decisions in these types of situations is probe, sense, response. So probe is to do kind of safe experiments, just try out different things and then see how they go, and then scale up if they work, or pull back or scale down if they don't work. Because we don't have this kind of neat and simple answer for in such a complex environment. And that's been the approach to our healthcare work during the pandemic. So I just wanted to share that as a frame. So what we're doing is, for better or for worse, I have most of my professional experience has been in the UN and with international NGOs, and I've worked in humanitarian situations. And so just drawing from that experience, I know that if in the middle of a crisis, you ask healthcare workers or first line responders to, hey, stop what you're doing, come join us for an hour for a workshop on compassion, the attendance numbers may be quite low. And so we've taken the approach of meeting healthcare workers where they are. And so kind of our first offerings have been designed to be really accessible and easy to use, and how to incorporate compassion, self-care, resilience, steadiness of mind throughout the day. And they're also free and downloadable. And we've obviously consulted healthcare worker colleagues to make sure that our offerings are grounded and relevant in their experience, in their lived experience. And while there's a component of compassion for others as part of our offerings, we're really focusing on the resilience aspect, self-care, a bit of trauma prevention. I'm very humble about what we can achieve in that domain in this moment. Metabolizing, managing strong emotions like anxiety, fear, steadying the mind when our nervous system is really activated. And as part of our other ongoing programs, we've also started to offer just free drop-in sessions, many of which are hosted by JIMPA for those of us who do have the time and can join live. And then those sessions are now being recorded and available on social media as well. So one of our first experiments has been the care package for healthcare workers. And in this care package, we include short guided meditations. So meditation to do at the beginning of the day to prime the mindset and to prepare oneself for the day. Meditation for the end of the day to kind of be with what's happened, let go of things that aren't helpful, and to ground again in the sense of support and care that we all have in life, but that we might not feel in that moment. And also meditation to, in moments of kind of extreme anxiety or intense emotions. We also have downloadable offerings, so a booklet and some cards that can be printed and laminated if that's available so that they can be wiped down. And the booklet and cards have kind of on-the-spot practices that can be done in a few seconds to a few minutes for different types of scenarios. And we're also putting together short practices that can be done as a team, you know, during huddles or during team meetings, all weaving in the compassion and social connectedness and support element. And while we acknowledge the broader system and institutional and political shortcomings and the context, we're really in this moment focusing on supporting the immediate well-being of the healthcare workers, which also has an impact on the quality of care and patient outcomes. And where we do have institutional partnerships and where we're able to kind of offer ongoing programs, we are rolling out our programs with longer term sustainability and intentional systems and culture change in mind. So for example, with a university partner, we're exploring ways to embed compassion into the existing medical education and training. With another institutional partner, we're looking at what does compassionate leadership training look like during this pandemic. And with a large metropolitan hospital that has adopted compassion as one of their core values, we'll be rolling out an existing compassion-based burnout prevention curriculum that we have to support their operationalizing compassion. So just in wrapping up, I just want to again thank everyone here on this call for everything that you're doing. It's really heartening to be part of a group that is advocating for compassion at this time. Crises, personal, global, are definitely challenging times, and they are rare opportunities for deep change and transformation. So I really look forward to seeing what we can achieve collectively. And if anyone has any questions, please feel free to reach me at jane@compassioninstitute.com. Thank you.
Thank you so much, Jane. That was really, really instructive. And thanks for all the work that you and JIMPA and your teams are doing with healthcare workers, particularly during this time. I just wanted to let folks know that we will be posting a compassion hub of resources here at the task force in the next few days. And we will send out an email to all of the folks on the webinar today to let you know how to access that link, and it will include the resources that Jane mentioned from the Compassion Institute. I'd like now to turn to Matthew Lee, who's the Director for Empirical Research at the Human Flourishing Program at Harvard. Matthew has a lot of experience with organizations. Jane has talked about compassion at the individual level, and now Matthew will share with us some perspectives from the organizational perspective, particularly from the perspective of flourishing. Matthew, it's great to have you.
Great, thank you, David. I'm glad to be with everyone. Yes, my comments are a nice complement to Jane's remarks. Some of us are working with frontline healthcare workers who are just working frantically to save lives, and others are engaging with groups who are more or less idled by the COVID crisis and have lots of time on their hands. And so I think that, you know, my remarks will allow us to step back and think about the broader organizational and maybe even systemic level and what the opportunities might be. I'm going to focus on the centrality of love and compassion to individual, community, and planetary flourishing as these are interconnected. The level of suffering associated with the COVID crisis, of course, defies the imagination, and the need for love and compassion is greater than ever. We all recognize this. We have a collective opportunity to reorganize our societies and communities and organizations with love and compassion as guiding principles. There will be a lot of disruption and a lot of work to be done to do this reorganization. This work should probably include a willingness to notice what is going right, to keep our eye on the helpers, as Mr. Rogers famously said in the wake of the 9/11 attacks. This engages the reward centers of the brain that are associated with compassion, not just the pain centers associated with empathy. Many of us have been operating from the pain centers primarily, but compassion must involve spreading joy through supportive connections at the interpersonal level, and by reorganizing the macro levels around principles of love. Otherwise, socially determined deaths of despair may end up claiming as many lives as the coronavirus itself. As the COVID crisis lifts, our awareness from related distractions of workism and consumerism, again, for those who are not frantically saving lives right now, we must recognize that we have a new freedom to collectively reorganize, guided by the principle of love. But let's not get stuck in lofty abstractions. Instead, we need to be specific in a way that is urgently needed at this time. For example, COVID shows us how precarious it is to construct healthcare as a benefit of paid employment when millions of people are almost instantly thrown out of work through no fault of their own. Surely any sane and rational understanding of love would include some basic level of healthcare for all, regardless of ability to pay. Whatever love might mean, and we can start with Aquinas, who understood it to result at least partly from the desire to contribute to the good of the other, surely it must be both effective and extensive. In other words, love should make a positive difference in the lives of other people. And we should expand the circle of care and concern to include all others without exception. Two frameworks that might be helpful for tracking our progress along these dimensions include first, donut economics, and second, the concern with legacies of vital conditions associated with a well-being economy. So if I'm able, I would like to share my screen and show a couple of images. I'm not sure if you all can see this first image.
We can, Matt.
You can, okay, great. So this is donut economics, and the idea here is to try to balance meeting the needs of people for basic access to food and water and healthcare with Maslow's higher levels of needs around peace and justice and equity, and we would add meaning and purpose and other domains, character and virtue, to these social foundations. So trying to meet the needs for these social foundations without exceeding the ecological ceilings, without overshooting the carrying capacity of our local and global environment to support what we're doing. So I think that's a helpful way to think about well-being that's not just about measuring the happiness or the complete flourishing of the individual, but takes into account the effects of these patterns of flourishing might have. Secondarily, I would, in the last minute or so that I have, would like to direct us to this model of the dynamics of well-being and equity that I alluded to, developed initially by the Well-Being in the Nation Network. And I'm happy to share these and other related resources if folks want to get in touch with me through the Harvard Human Flourishing Program. Oftentimes we are more or less stuck in an adversity economy, dealing with immediate needs, trying to solve problems rather than thinking about expanding vital conditions. And so if we are going to be effective stewards of the larger systems in which we find our organizations and ourselves, our communities embedded, we have to do more to focus on expanding vital conditions and leaving a legacy of expanded vital conditions for all people without exception. And this involves, for example, not just building prisons to try to control crime, but expanding basic health and safety nets, providing humane housing and opportunities for thriving and flourishing in ways that prevent crime. And it's the same thing with healthcare. It's not about getting people with lifestyle medicine problems on maintenance medications for life, but rather about preventing those problems from emerging in the first place, or working with people through oftentimes support networks to solve some of these lifestyle related problems, which account for so much of the healthcare costs and the bad outcomes that we see. So moving us out of this kind of adversity economy mode and into a well-being economy mode, I think is a really helpful way for us to think about the work that we're doing as we try to promote flourishing at the individual, community, organizational, and societal, and ideally global level. I think I'll end with that. Thank you.
Thank you very much, Matt. Appreciate those comments and the frameworks that you shared with us. I'd like to move now to Tanya Wood, who's the Executive Director of the CHS Alliance. This is a coalition of humanitarian organizations, and they've been on a parallel path as similar to those of us in global health, looking at how do we actually bring compassion into the center of our thinking and our doing and our being. And so we'd like to look over the edge here, look over the bow and see how you're doing there in the humanitarian sector, because we need to learn from you. Tanya?
Thanks so much, David. Can you hear me?
Yes, we can.
Great, thank you. So thank you, David, and hello to everyone. I'm calling in from Geneva today, and as David says, I work for an organization called the Core Humanitarian Standard Alliance, which tries to get all of our members to meet the commitments we've made in the standard, which really are to the people affected in how they receive our aid. And as David says, part of this has been a learning journey that we're on, and like you all, in terms of how do we through that build a caring and compassionate organizations for us to be able to do it. So I'm going to talk a little bit, kind of continuing this theme of balance around what some of the challenges and opportunities we have in COVID and our humanitarian response. And much of it echoes, but some of it is slightly different, and it's great to have this chance to learn and share. So I think obviously for the health world, it's creating huge challenges, but it is for us as a humanitarian sector. And I think one of the main reflections I have is really about how it connects between the self and others. And we're all in that balance in our personal lives about how our own behavior and actions affect others. But as leaders of organizations, we're all faced with it as well. And particularly for us in the humanitarian sector, as in the health, where we're trying to see on how we protect our staff and our volunteers, but at the same time, do what we're meant to do, which is respond to humanitarian needs. And any crisis, and this is why the core humanitarian standard was established, is any crisis forces us to rethink how we're doing things, and hopefully we improve. And at the moment, as Sham said at the beginning, we're in a very active learning phase of how the sort of core commitments should work and how do we adapt as we move along. So I've got 3 challenges that I see, challenges and opportunities. I might lean more towards the opportunities for the humanitarian sector at the moment. And one is, I really hope and I feel that there is a push towards a refocus on compassion, and this crisis will push us into that. You know, the humanitarian sector, we work on, our mission has been fast, life-saving, but the difference maybe from health is the sort of scale of what we're looking at. We don't focus on the individuals, we focus on the mass scale. So we've invested really heavily in almost machine-like bureaucracy to get there as quick as possible, serve as many people as possible, and that's what we've got very good at. But unfortunately, the swing back from that is, have we done that at the expense of compassion? And you know, we've purposely and in connection and discussions with David, we've kind of purposely used this term compassion to see how it sits with the humanitarian sector, because love and compassion to a humanitarian audience, it starts to feel a little bit squeamish, a little bit squidgy. That's not what we're about. And you've really got to question and challenge, like, have we really neglected our kind of fundamental principle of humanity if we're not using those terms in our day-to-day language? So I'm really hopeful that COVID is bringing back some of that, and we're seeing more signs of how people are talking about compassion and care. But also, by the reality of what we face now, COVID means that our usual humanitarian response mechanisms aren't working in the same way. It's a huge disruptor to how we do things, because normally we jump on planes and we pirouette into somewhere, and generally we can't do that. And we're also having to be pushed with how we build care and compassionate aid organisations right now. We have to look at how we be more compassionate to our staff. We've got to think about how we're building cultures of care, and how do we look after the well-being, where somebody earlier said everyone's in very different scenarios and situations and personal situations that they're challenged with. And I think what will be judged, as we've been judged before, particularly in the humanitarian sector, we were judged very harshly and rightfully so with the Me Too movement. We got very public rebuttals when organizational behavior doesn't live up to its values, and we have to get it right in this crisis. It's another chance for us to really start to think whether our values, whether we're living our values as organizations in the practice we do. The second one is the sort of connection between global and local. And I think this is going to be the biggest lesson of how COVID, and we'll look back on, is how those connections are made. And the opportunity we see at the moment in the sector is the connection where we're really reliant, as we always do, on the local response. But then maybe we've got this chance where the international system really can be a support to the local. And that's been a challenge for us in the sector when we're so used to just swooping in with the large organizational missions behind that. So time will tell whether we can actually learn and adapt to a different way of working that's much more locally sensitive than we've done in the past. The challenge is obviously whether this sort of will make us more globally compassionate, or whether it will make us start to be based on fear. And time is going to tell on that one, whether we're going to end up, whether, as Liz says, we can come together more and this will force us to try and connect and see the human empathy, or we'll be challenged as a sector with even more refugee and IDP crisis as borders close down and there's more fear of the other. And I think that's where we've really got to drive the compassion. And then the final one is the inequality in all of this. And I suppose this is more just the plea that we're very conscious about. And I see there's a building of conversations in all different sectors, which is around this inequality and this idea that any of us are in this together. As with any disaster, we're all impacted, but our ability to sustain it is going to be very unequal. And so, the hope is that the real power of compassion in this is if we start to really, again, focus on the inequalities that drive the challenges and the vulnerabilities of people, because the COVID, where that will be one of the biggest lessons learned of how the inequality have impacted people in such different ways again. So those were some of the opportunities and challenge at a sort of global scale we see. Are we going to be able to live our values? Are we living our values in our organizations? Are we adapting and caring for our staff? How do we build and support local institutions and learn from that? And can we really start to use the language of compassion in building kind of global empathy and support? As David says, we're working on a very similar project, so it's excellent that these conversations are having, called Cultivating Caring and Compassionate Initiatives, which really is about, we're having a series of global conversations, and we really believe that having these conversations is what builds compassion. This is relationship building. And so I'm just so positively optimistic that if we can keep these conversations going about compassion, and we start to see that language in the humanitarian sector and in the health sector, we start to build a different culture of compassion that can only do good. So real thank you for David for continuing these conversations and learning from each other. Thank you.
Thank you very much, Tanya. So much of what you said resonates with us, and it's really helpful to get your perspective. We have had such a rich contribution from the reflectors, and many questions have come in. I'd like to turn it over to Shams now for the impossible task of moderating maybe one or two questions. I would suggest that we might run over by maybe 5 minutes or so before we close. So Shams, over to you.
Thank you, David, and thoroughly enjoyed listening to all those reflections, and it's more or less impossible to ask all the questions that have been put forward, or any of the key points that have been put forward also by those that have been typing in. But if I may just turn to just a number of the colleagues just for specific questions. So there was one particular question that perhaps would be addressed to Liz. And this is a question related to how would you modify the mitigation measures that you are describing to reduce the unintended consequences of our public health approaches to COVID-19, and particularly at the end of life, Liz?
Thank you. I think that's so important. Some of this is about how do we fill that space at the end of life with supportive conversations. Even when we can't be physically close together, there are ways of sharing now through technology. Can we increase that? Can we support the health workers who are caring at the end of life, who haven't been trained to care? Can we support those health workers by providing virtual support, by providing some indicators of messages that we can say, or that they can use some framing of the ways to describe what's happening as they break very bad news to families, as they break very bad news to patients, as they help patients think about the next stage. Can we help alleviate the stress of the health workers? But also around the neighbourly support is what was mentioned. I think that there's a joy in the compassion, in recognising the random acts of kindness and the compassionate acts that so many people are giving almost unnoticed. So can we actually celebrate those as well, particularly again for those who are coming, for those who are with those who are caring at the very end of life. I'll add some more thoughts into the question box, but because I know there's other questions, but those are the things I would want to flag up at the minute.
Thank you so much, Liz. And of course, we could carry that conversation on for a number of hours. Temi, just moving all the way to West Africa, what is the one actionable point that you would like to highlight from the reflection that you have provided? So one actionable point for you that you suggest others to consider from the reflection that you provided. Temi, if you can hear us.
Yes, certainly. Thanks, Sam. I would like more emphasis to be placed on training for healthcare providers, training relative to compassion as much as possible. I think this is one place we need to strengthen. And as we're able to do this, it sinks down into the culture, the practice, and it affects the quality of services we provide for these patients. Over.
Super, very clear, very succinct. Jane, there's another question coming in which I'd like to direct to you related to PTSD, which clearly is and will be more of an issue as we move on. How can we quickly deploy something to address this through a lens of compassion?
Wow, great question. I want to kind of sit with that for a bit, but there is a lot of overlap, because in at least compassion training as we frame it, it's working with the mind and the body and the nervous system. And so what we're trying to do is to incorporate a trauma-informed lens into the compassion training and offerings that we have available and that we're developing. So, you know, things like, for example, right now, a very common guidance in a lot of meditations is to focus on the breath. Right now, that can be really challenging if you're wearing a mask. If you have COVID-19, you know, so thinking about, there are trauma sensitive ways to gather the mind and attention without using the breath. And there are ways that in which for healthcare workers specifically, you know, I think we're watching collective trauma unform as a society, as a world, and in healthcare and first line responder communities. And so I think part of helping to minimize the trauma is also, you know, just day to day letting go of things that you can't control, not holding on to it. I mean, there's, in the healthcare profession, there can be a tendency toward, you know, being a hero. There are expectations of healthcare workers to be heroes, to be superhuman. And then, you know, some healthcare workers to put that responsibility on themselves. And that's a lot. In the middle of a pandemic, that can be overwhelming. So there are very practical and specific ways to bring the two together.
Thank you, Jane. I'm just wondering whether Maria is still with us, and if so, Maria really started us off with a thinking around wider pieces on things like food security and also markets and the wider effort of society, orphans. Now, Maria, if you can still hear us, what are the big number one barrier that we need to overcome to enable action on compassion to succeed? Maria.
Shams, it appeared that she's not on anymore. Yeah.
Okay, so if Maria is no longer able to connect, I'm just going to come to Matt. one question for you, Matt, in terms of the emphasis that you placed on human flourishing. What do you think one biggest contribution that compassion can make in the delivery of quality health services?
Yeah, that's a great question. The biggest impact that compassion could make to the delivery of health services is a recognition of the whole person, both the person being served and the person doing the serving. That dynamic is absolutely critical, not just to healing in a physical sense, but, and certainly the book Compassionomics has systematically reviewed the empirical literature there, and it's very striking, very impressive. But also making a contribution beyond just narrow physical health to the complete well-being or flourishing of both people involved. And that's sort of a model then for reorganizing other institutions. The more we do this in the healthcare sector in this time of crisis where it's needed so badly, the more that serves as a model for us to do it in the field of education, the field of business, and other sectors.
Thanks, Matt. Just going to Tanya, last question. Really a very similar question to you, Tanya, because of your leadership in the Humanitarian Standards Alliance, the Core Humanitarian Standards Alliance. Organizations that are looking at compassion and linking the compassion work as a driver for organizational effectiveness in some of the most difficult places on the planet. If there was one message that you wanted to leave us with, what would it be?
Thanks, Shyam. I think it's really this issue of kind of building a culture of compassion within organizations. We have the idea that we're really promoting on the kind of be well to serve well, and that we really have to, as organizations, shift our culture of kind of looking after our staff and looking after each other to be able to serve those better. And I think, as I mentioned before, we're on a culture that promotes that, and that we look after each other as well so that we can look after others.
Thanks very much, Tanya. I know time is short, so I'm going to hand back to David to close up, but I just wanted to just thank everybody, and it was really a wonderful privilege to listen to all of you. And particularly in the spirit of the work that we're doing, the whole concept of sharing and challenging each other, and the humility, the word has been used a number of times, and we've still got a lot to learn in this space, but we sort of need to accelerate our learning for the action that's required. And I think all of us are also thinking through how we're sparking thinking in ourselves so that we can spark thinking in others. So a great opportunity to learn from you all. Over to you, David.
Thank you so much, Shams. And speaking of humility, Laura Berland and Evan Harrell, who are at the Center for Compassionate Leadership, agreed to cede their time, given the fact that we were a little bit ambitious in bringing in so many excellent panelists. But I would like to pose a question to them, your question to them. What one thought would they like to leave us with to move compassion into quality healthcare and to address the COVID situation in particular, if you have it? Thank you.
Well, I think that it's a variation on what Tanya just said and what Matt Lee also said, which is that the human element is the most critical aspect of what we need to bring. It's very easy to proceduralize clinical aspects of practice, but to bring the emotional practices and to bring the heart to bear is something that requires strong intention and regular practice. So the humanity of all of this is what is the most central, and it's something that we really need to be focused on.
Yeah, and I just want to amplify what Shem said. The amount of love and care that's been in the container of this webinar, the opportunity to listen deeply and to learn from each other is extraordinary, and very grateful to be here with all of you to hopefully we're all cultivating a better world through compassion. Yeah. Thank you.
Thank you, Laura and Evan. And again, apologies that we didn't give you your fair time. We'll bring you back in our next quarterly compassion rounds for sure. I'd like to thank Shams and all of the team at WHO for their leadership on this, and also all of the panelists, the reflectors, for some really great presentations and a lot for us to consider, reflect on, digest, and think about and put into practice. It's hard to condense all that you had to say in such a short period of time, so I appreciate the impossibility of what we were asking you to do, but this was really, really wonderful. We will be sending out a report of this webinar, and I can't promise exactly when it will be, but in the next few weeks. But before that, we will be posting a compassion hub of resources on the task force website, the FACE website here at the task force. And it will include references to some of what Jane mentioned at the Compassion Institute, the Center for Compassionate Leadership, and the CHS Alliance. There will be links to some of the great resources that they have developed, as well as other materials to support each other and the people that we work with. So once that hub is up, hopefully in the next 2 or 3 days, we will send an email out to all of the participants of this webinar so that you'll be able to access that. And then expect a report out of this meeting soon. We thank you for all the participants that have sent in questions and comments. We will digest those, we'll record them, and we will try to address some of those in the report as well. We may farm some of those out to our panelists for continuing the conversation. I just want to thank all of you for such a rich sense of community, of practice that we're building. It's so encouraging to know that we're not alone in this isolation that we are practicing and in trying to move the world to a better place. These crises are always opportunities for positive change, as well as for grieving and for attending to the losses that we're experiencing. So I want to thank all of you for the work that you're doing and look forward to our next time together, roughly 3 months from now, but we'll be in touch with you between now and then. Thanks so much.